let's get into it then. So this is going to be the very first lecture of the semester, Survey of Neuroanatomy, Appendix Part 1. This survey of a neuroanatomy and the appendix section is going to be involving 3 different lectures. So there's going to be Appendix Part 1, 2, and 3. And this is kind of an overview of neuroanatomy as well as kind of an introduction to certain diseases and the way that the brain works. There are going to be certain topics that we're going to cover in the appendix that we're going to go into much more detail later on. So, for example, we're going to kind of briefly talk about Parkinsonism. We're going to briefly talk about the basal ganglia. But when we get into the actual basal ganglia chapter, we're going to go really heavy into the weeds on the basal ganglia, all the different regions of the brain that are involved in movement control, and all the neurotransmitters involved, GABA, glutamate, right, dopamine. So we're going to talk about all that stuff in much more detail later. So this is kind of like we're skimming the surface here before we delve heavier into the weeds. And I also am a huge fan of art and like medical science or medical history and things like that. This one in particular is quite interesting, right? Phrenology was a thing that was actually practiced as a semi-legit scientific practice back in the 19th century. And phrenology is a bunch of garbage, basically. Now we actually do map out the brain and the different regions of the brain. We're going to talk about, for example, Broca's area, Wernicke's area, and all that, and how like different regions of the brain are responsible for different types of function, whether it's speech, memory, facial recognition, vision, sight, all that stuff, right? And so this was kind of like 19th century approach to trying to figure out what the different brain regions were responsible for. Perceptiveness, acquisitiveness, right? Sublimity, whatever that means. Reflectives, conscientious. It's all just a bunch of silly stuff. And then on top of that, not just silly, but it was also used by a bunch of like eugenicists. You guys know what eugenics is, right? Who knows what eugenics is? You guys don't know what eugenics is? You know what eugenics is?
Isn't it like you kind of manipulate people and the population so you get rid of what is bad?
Yeah. Exactly. Eugenics was a movement that kind of grew out of the 19th century and then into the early 20th century. Hitler is one of the main eugenicists that comes to mind, right? But there's a bunch of eugenicists throughout history, and a lot of these guys were actually sometimes like medical doctors who were studying the brain regions of different races of people and coming to the conclusion that, certain races are superior to other races because of brain development. It's all garbage, right? All that stuff is just absolute garbage. Not scientifically based at all, right? That's all just basically pseudoscience. But it's interesting history, right? Neuroscience does have some very interesting history. And we're also going to talk about some horrible things that were done in the mid-20th century. For example, lobotomies, leucotomies. Right, the guy that created the lobotomy got a Nobel Prize in medicine, right? And we look at that in horror nowadays, right? We look back on it in horror and it's just like, wow, I can't believe that actually was so widely practiced. Absolutely insane. So we'll talk about that in more detail later. What was your question?
Where did they hit the lobotomy?
In the frontal lobe. And then the lobotomies, it evolved into a leucotomy. And so you can actually buy like vintage like leucotome kits, which I really want to get. There's a website that they sell a bunch of like old vintage medical stuff. So you can find leucotome kits. And so they would go up through the orbit of the eye, and then they would tap, 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 and they would wipe out areas of white tract within the frontal lobe. And the idea is it used to be used at first to treat schizophrenia, psychosis, those types of conditions. And then it kind of evolved beyond that to treat unruly housewives. Like some guys would be like, my wife, she's acting up. Come on, doc, help me out. And then they would like lobotomize the wife. I'm not joking. They would actually do this. They did it to John F. Kennedy's sister in the 1960s. Actually, I don't know if it was in the 1960s. It might have been in the 1950s. But John F. Kennedy's sister, right? President Kennedy's sister was lobotomized because she was acting out of control, right? Pretty wild stuff. Super misogynistic as far as I'm concerned. But it's history, and it happened in medical history pretty recently. Right? This is recent stuff. And then I like to talk about that kind of thing. Lobotomies, for example, like we look at that in horror, but there's certain things that are going on nowadays that we're probably going to look back on with horror as well, right? Things that are happening nowadays, we're going to look back on and be like, what the hell? How did anybody like greenlight that, right? So medicine evolves, medicine evolves and people's perceptions also evolve as well over time. So pretty interesting stuff. So here's an overview of what we're going to be talking about today. And how long does this class go until? 10:45? You're like, it goes until 9:45, right? All right, class dismissed. So this is the overview of everything we're going to be discussing. So we're going to be looking at different features like surface, so like the real estate of the brain, right, and what those different regions are responsible for. We're also going to talk about embryological brain development very briefly. We're going to go into it in much more detail in a couple weeks. We're going to talk about brainstem, a little bit of cranial nerves as well. Again, cranial nerves, we're going to go really heavy later on this semester, but we're going to do an overview for now. Blood supply, right, and how that has implications in, for example, strokes, right? Flow of cerebral spinal fluid. We're going to talk about the meninges and the blood-brain barrier, right? The blood-brain barrier, which basically regulates what can go from the blood into the brain, right? Certain drugs, for example, can indeed cross the blood-brain barrier, right? And those are drugs that usually have some form of psychoactive effect. So we'll discuss that later on. And here's another thing that I'm finally doing this semester. This is the first semester that I'm not having to develop a brand new class or teach a brand new class. So I'm like kind of coasting now. And so now I can actually like do some Christian worldview integration into my courses. So I finally have time to do that. So when I do this for my classes now, I like to try to at least make it somewhat relevant to the material that we're going to be discussing in class. Sometimes it might not be completely relevant, right? But still important nonetheless. So this is from Romans chapter 12. Do not conform to the pattern of this world, but be transformed by the renewing of your mind. Then you will be able to test and approve what God's will is, his good, pleasing, and perfect will. And I also, again, I'm a huge fan of art, especially like psychedelic art like this, right? This is a piece by Alex Gray. I use a lot of Alex Gray's work in my lectures in general, even, beyond this stuff, right? Alex Gray is a phenomenal artist. He's still alive to this day. He's 70 years old now. I was actually looking into him yesterday. Have you guys ever heard of Alex Gray before? You should have, because of yesterday. So Alex Gray, you've probably seen his work before. He's got a lot of really famous pieces. So you've probably seen it, but you didn't realize it was Alex Gray. And he actually studied anatomy, and he was a medical illustrator for Harvard Medical School for like 10 years. I didn't even know that. This is how he like basically learned how to do anatomy. He was actually dissecting and illustrating dissections for Harvard Medical School. And so he did that for quite some time until he was able to fund, basically like start making money off of his more like creative type work, right? And he's very well known for doing lots of interesting like spiritual, psychedelic type art. Very, very, very talented guy. Anyways, so that's one of his works, and let's move on. So the brain. The brain is only 2% of all your body weight. So it's a pretty small organ, but it's highly metabolic. So much of your metabolism is going to be dedicated for brain activity. The brain constantly needs to be stimulated, right? In order for it to, well, not constantly stimulated, but it needs a constant source of like energy and nutrients to be able to function, right? When you go to sleep and you're in a fasting state at night, right? What's the metabolic, what does your body do to be able to create glucose? What's like one thing that your body can do metabolically? You guys have taken AMP, right? I know you guys were in a couple of my classes. So if you're in a fasting state, what's the thing that's going to be released? It's a hormone. Glucagon, good, yeah. So when glucose is gone, your pancreas releases glucagon, right? So then you can actually create glucose. Other things that happen metabolically, right? What's a way that your body stores glucose? Fat, sort of, huh? In muscles, what's the thing in muscles that's stored? Glycogen, good, yeah. Glycogen stored in skeletal muscle, also stored in the liver, right? And so when you get glycogenolysis and you break down glycogen, now you're able to release glucose into the bloodstream, right? The brain needs a constant supply of glucose for it to function properly, right? And if you're in a situation where you're like, for example, let me think of a good example here, like cholera, for example. Cholera is a condition where, you basically lose all of your body fluids rapidly. So much of your body fluids in a short period of time. Basically, your body starts to triage. And you can, patients who get cholera, they're fully aware. Their brain is still functioning. And they can actually, sense as their organs are all going into organ failure. The last organ in the body that goes into failure is the brain, right? The body has a way to protect the brain at all costs, right? Because the brain is it is actually the most vital organ in the body. You got a question?
Yeah, so when some people have low blood sugar,
Yeah.
they faint.
Yeah.
Is that because of
Yep.
a brain that doesn't?
Yep. It's 100% the reason why. So the question is, if you had low blood sugar and you faint, is it because of the brain not getting the energy it needs? Yeah, 100%. As a matter of fact, we had like I said, I worked a lot in psychiatry, and so we would see a lot of suicide attempts. And one of the saddest ones was this nurse. She was in her 60s, and she had lost her job. I think she either lost her job or she lost her license. I can't remember what it was. But she went home, and she took a lethal dose of insulin. Right? That's a really scary drug. Right? If you take a lethal dose of insulin, your blood sugar tanks completely. Right? So hypoglycemia can be very dangerous. You can die from that. And so she almost died. Well, she did die, actually. She passed out. She fell to the ground. She broke her nose. So when she came to the hospital, her face is all battered. Luckily, she had a roommate, and her roommate found her on the ground. And so she survived. But yeah, so if you go hypoglycemic, you will die from that. Insulin overdose is very dangerous. And it's scary, especially if you have a patient with diabetes and they also have Alzheimer's. Right? Sometimes they forget when they take their dose of insulin. Right? So you have to have somebody helping those patients, right, to administer their insulin properly and at the right times, and not to have a person gives themselves insulin and then they forget and they give it to them again. Right? That can be very, very dangerous. So yeah, that's a really great question. Neurons are going to be transmitting tons of signals per second. And the brain is going to be constantly active. Different regions of the brain are going to be constantly active. There's a popular myth that we only use a small percentage of our brain at any given moment, 10% of our brain. Right? That's not entirely true. Right? Our brain is going to be constantly active. But certain areas are going to be more metabolic than others, depending on the circumstance. Right? That's the whole entire idea of using functional MRI or PET scans, things like that, to be able to see different regions of the brain light up due to different activities. But the brain is always going to be in operation. And then alcohol, some people say that alcohol kills brain cells. Not entirely true, but what it can do is it can result in a condition called Wernicke-Korsakoff syndrome. And Wernicke-Korsakoff syndrome is where you're wiping out this little region called the mammary bodies in the brain, and you get a couple things happening. You get confabulations, right? The patient starts to kind of develop like a form of dementia, basically. So they'll have dementia, and then they'll do this thing called confabulation. Confabulation is where a patient basically just lies to you, but they're not intending to lie. You can ask the person, be like, "Oh, what did you have for breakfast today?" They'll be like, "Oh, I had an omelet with, a side of hash browns." And it's maybe they didn't actually have that, right? They just kind of come up with these lies. So really fascinating stuff. It's Wernicke-Korsakoff.
You have to drink a lot, though, right?
Yeah, you have to be a heavy drinker. Are you concerned? Are you getting nervous?
B1 vitamin.
Yeah, I started taking thiamine. You guys started taking B1 vitamin. So alcohol can cause damage to the brain, but it's not going to necessarily kill brain cells per se, right? But we are going to talk about alcohol, especially when we get into seizures because of delirium tremens and all that, right? Very dangerous seizures that are going to be due to alcohol withdrawals, not the alcohol itself. Although you can go into alcoholic hallucinosis if you're really, really blitzed. I'm talking you have to drink a lot to be able to get there. But it happens. Some people go crazy on just booze by itself. Now, when it comes to orientation of the brain, orientation of the brain is kind of interesting because it's going to be based off of animals that are on a horizontal plane. So think about fish or quadrupeds, right? Remember in basic anatomy, you had anterior, posterior, but you also had ventral, dorsal, right? Ventral's the front, dorsal's the back, right? And we're going to talk about that, especially when we discuss ventral and dorsal root ganglia. Right, dorsal root ganglia are going to be the ganglion that come off of the posterior portion of the spinal cord, and those are going to be sensory, whereas the ventral roots, or ventral horn, is going to be mostly, it's going to be motor function, right? And so that direction applies to everything below the brainstem, basically. But when you're actually discussing the the cerebral cortex, so the cerebrum, the dorsal aspect is going to be on top. Right? Just like if it was a fish, right? So dorsal, think about the dorsal fin on a fish, right? Ventral fin on a fish is on the bottom, right? So it's going to be the same type of orientation when it comes to the brain. But that's basically it. Once you get down to the brainstem, then the normal like dorsal, ventral orientation applies at that point. And then you have anterior, posterior, right? Superior, inferior. Right? So those are going to be the terminology that we use. You can also use rostral and caudal, right? Rostral is going to be front, caudal is in the back. And it's kind of weird because caudal means tail. So this is like the tail of the brain. I don't know, it's kind of weird, right? But you can still use that type of orientation for the brain itself, right? The cerebral cortex. But then rostral caudal is going to be more aptly named when we discuss brainstem all the way down to the spinal cord. And then at the very end of the spinal cord, you guys, some of you who took A&P, what's that structure at the very end of the spinal cord? Cauda equina. Good. Yeah, exactly. What does equina mean?
Like horsetail.
Yeah, horsetail. Absolutely. Yeah, cauda equina is the horsetail. And so that term, you'll see it again when it comes to actual basic anatomy. Definitely know your planes of dissection. The easiest one that I have here is sagittal because of Sagittarius. What's Sagittarius?
Crazy.
Yeah, Sagittarius is crazy. I dated almost every one of my ex-girlfriends was Sagittarius. And yeah, you gotta learn the hard way. Apologies to anyone who's a Sagittarius in this room. So what is a Sagittarius though? It's a centaur that carries a what? A bow and arrow. How do you shoot a bow and arrow? Right? So right down the midline, you can be mid-sagittal or you can be parasagittal, which is adjacent to. Like anytime you hear para as a prefix, that means adjacent to, next to. All right, so sagittal is going to be the easiest one. And then you have the next one, which is another somewhat easy one. I have a good mnemonic for this. Corona. What's a corona?
Oh, beer.
Yeah, it's a beer. Exactly. Great. It's also a crown. Exactly. Corona is a crown. How do you put a crown on? Yeah, like that. So coronal cut is going to be like so, right? And then you have the last one, which I don't have any good mnemonics for it, but horizontal, axial, or transverse. So right down the middle. Now, know what you're going to be looking at, right, when you're looking at a sagittal cut. If you get a sagittal cut, how are you going to be looking at the specimen or patient or whatever? Yeah, from the side, exactly. Sagittal view is going to be from the side. Coronal view is going to be either anterior posterior or posterior anterior. And then lastly, axial or transverse is going to be top to bottom or bottom to top. Okay, so make sure you know your planes of dissection.
Oh, I have to tell you, by the way.
What's up?
In Spanish, rostro.
Yeah.
Rostro means face, by the way.
Oh,
So front.
I didn't know that.
Yeah. Your rostro is your face.
Rostro.
In Spanish.
Interesting. Rostral. That's very, very cool.
So when you said that, I was like, oh. This is
Heck yeah. That's great, man. That's good. Very good. And so here's another image that shows all that. So you got a nice little CT scan showing the different planes of view, right? Sagittal and whatnot, coronal, etc. What's number one? Sagittal. Good. What's number two? Coronal. 3? Transverse. Transverse, axial, horizontal, whatever. Any of those 3 would be suitable. Here's a really cool image of an MRI going head to toe. So this, what kind of view would this be? Transverse or axial. Yeah. So this is really, really cool. And what I love about MRIs, and we're going to be discussing different medical imaging techniques and approaches. So we're going to be discussing X-ray versus CT scan versus MRI versus functional MRI, etc. And MRI is really, really good for looking at soft tissues. So soft tissue injuries, especially, MRI is going to be really good. And it's one of the safest of all of the imaging technologies, right? Why is it safest? Yeah, no radiation. It's magnets, right? So magnetic imaging. Whereas CT scan is probably the most dangerous of them all, right? What's a CT? Huh? No. Well, computerized tomography. But what does it actually do? What's a CT scan?
I did one, but I don't know what it is.
You did one, but you don't know what it is. It's basically a glorified X-ray machine. So 360 degrees, right? So you're getting a ton of X-rays. So you can get a 360-degree image, and then it's computerized, so they can render a really nice 3D image. We have a CT scan over here. It's for rodents, not for humans, right? So it's like a CT scan, but smaller. It can like fit on this tabletop right here. And it's got like a little tube. You put the rodent in there. There's also like you can put isoflurane. I can't remember. Is it that? I forget what the anesthetic is. I think it's isoflurane. And you can basically sedate the rodent, put it into the CT scan, and you can do imaging. And the image that you can create, you can also computerize it. And I haven't learned how to do this yet on this machine, but you can develop a 3D model of whatever you're scanning. So really, really cool. So CT scans are super neat, but they're very dangerous. Lots of radiation, so ionizing radiation. So that's why MRI is a really good option for looking at soft tissues. The only problem with MRI, it's really expensive. CT scan is also expensive, but MRI is extremely expensive. Thousands and thousands of dollars to use. So here's a really cool image also that's showing all the different planes of dissection. All right, now, what does the brain consist of? Two major features of the brain are going to be gray versus white matter. Gray matter is going to be mostly made up of cell bodies and dendrites. Cell bodies and dendrites. Whereas white matter is going to be mostly made up of axons. Okay, what's the thing that surrounds an axon that allows a nice depolarization? Huh? Myelin sheath, yeah, absolutely. And so the myelin sheath is going to be very heavy in lipids, right? That's why it's going to be white in its color. And when we talk about white matter in the brain, we're going to be discussing them in the form of tracts. Right? You have different white myelinated tracts that go from the cerebral cortex all the way down the spinal cord. Right? And the other thing that's important to keep in mind as well is that white matter and gray matter is going to flip. Right? In the brain, in the cerebral cortex, gray matter is on the outside, white matter is on the inside. When you get down to the spinal cord, it's the opposite. Gray matter is going to be in the middle, white matter is going to be on the outside. So it changes when you go from the cerebral cortex down to the brain stem and spinal cord. Other things that you need to be familiar with, this is all basic terminology. Right? Gyri, those are going to be, I like to think of them as the top of the mountains. Gyri, right? And then you go down to the valleys, and that's going to be the sulci. So gyri and sulci. And if you have a really deep sulcus, that's going to be called a fissure. So you have the longitudinal fissure, you also have the Sylvian fissure, right? There's going to be different fissures that we're going to be talking about in a little bit here. Why do we have gyri and sulci? What's the purpose of this?
Survey?
Huh?
Like increasing survey?
Increasing surface area. Absolutely. Yeah. Does every animal have this? No. Yeah. Some animals have smooth brains, right? And actually, sometimes people are born with a smooth brain. We're going to talk about conditions that will result in that. That's called lysencephaly. There's a couple genetic mutations that can occur. So lysencephaly is where you're born with a smooth brain, and you're going to have some severe cognitive deficits as a consequence. But other animals just have smooth brains, and that's just normal for them, right? Rodents are an example, rabbits, right? So some small mammals will have smoother brains. I used to think that sloths had smooth brains, but they actually don't. Right? Sloths don't actually have smooth brains. They do have gyri and sulci as well. But a lot of smaller animals will have smoother brains. Cortex, right? All this is cortex, right? It's going to be gray matter. And then you have subcortical regions, which will include things like nuclei. We're going to talk about a bunch of different nuclei. Subthalamic nucleus. We're going to talk about the some of the nuclei that are involved in the basal ganglia later on in more detail. And then you have tracts. Again, those are going to be bundles of white matter, white myelinated axons. Yeah.
So the gyri, is it gyri or gyri?
Gyri.
Is it gyri like the top of the fold?
Yeah, it's the mountain. Think about the peak of the mountain.
Okay.
And then as you go down to the valley or the trough, that's going to be the sulci.
And then the fissures are
really deep sulci. Yeah, really deep sulci. So like right here, this is the lateral sulcus, which is also referred to as the Sylvian fissure. Okay. Central sulcus. Well, actually, that's not a fissure. I take that back. The longitudinal, sagittal, right? The longitudinal fissure, right? So if you get a deeper fissure, that's going to be a deeper sulcus. That's going to be considered a quote-unquote fissure. What else is important here? Moving on. So here's the transverse fissure. Right, the transverse fissure bifurcates the cerebellum from the cerebrum. The Sylvian fissure is also referred to as the lateral sulcus. I never call it the lateral sulcus. I prefer Sylvian fissure for whatever reason. And then the longinal fissure is what goes sagittal, right? Divides the left and right cerebral hemisphere. If you are to go deeper into this longitudinal fissure, you're going to find a structure called the corpus callosum. What does the corpus callosum do? Do you guys know? Yeah, it connects the left and right hemispheres. Absolutely. And so we're going to talk about corpus. When we get into epilepsy and seizures later on, we'll talk about a procedure called a corpus callosotomy, which is a procedure that's not really performed much anymore. It was performed more in like the late 20th century. Right now we have really good anti-epileptic drugs, so not really super, not like a very commonly practiced procedure anymore nowadays. So these are structures of your brain from embryological development that you do need to know. So you need to know the different embryological derivatives of the matured brain. So here's all the matured structures, right, as you develop into adulthood. And when you're developing embryologically, you're going to have first two major divisions. You're going to have the prosencephaly, and you're also going to have the rhombencephaly. The prosencephaly is going to eventually turn into the telencephalon and the diencephalon. What does the word telos mean? Do you guys know? I believe it's ancient Greek. But telos means you're like trying to reach towards something, right? You're trying to like reach a goal, right? Telos is kind of like your ultimate goal in life, right? The telencephaly, the telencephalon, is going to be what eventually turns into like the more advanced regions of the brain, right? The cerebral cortex. Also, the cerebral nuclei, so like the basal ganglia, for example, right? The cerebral cortex and the basal ganglia are very intimately tied together. Right? The basal ganglia is going to be responsible for moderating movement, right? Inhibiting movement and initiating movement. And so it's going to work very closely with the motor association areas of the frontal lobe as well as the premotor cortex. So we're going to talk about that later on. And then lateral ventricles are also going to be associated with this structure as well. Then you have the diencephalon, and the diencephalon is going to be responsible for a lot of like your important vital functions. So the thalamus and hypothalamus, right? The hypothalamus especially is one of the most important regions of the brain. It's kind of like a master control center of the brain. Do you guys know some of the things that the hypothalamus does? Huh? It can help control heart rate, respiration, sympathetic activity. Sex, yeah, absolutely. Sex can be controlled by the hypothalamus. Temperature regulation, absolutely.
Other regulations too, right?
Yeah, feeding, so hunger, thirst, right? So these are things that are vital for survival, right? So these are vital functions. And also developing certain releasing and inhibiting hormones, right? So you guys remember the HPO axis, right? The hypothalamus secretes things like, thyroid releasing hormone, TRH, that will stimulate the pituitary to release TSH. right? So it's going to be very important. The thalamus is also a really important structure. I like to think of the thalamus as a relay center for a lot of your sensory input. So you have your afferent. When you say afferents, we mean things that are coming to your brain, right? Efferents means exiting, right? So you have your afferent, your sensory afferents are routed through the thalamus, except for one. There's only one that doesn't go through the thalamus. Which one is that? Do you guys know?
Is the one that was like adrenal gland?
No. Which sensory special sense, right? So it's either touch, smell, sight, hearing, or taste. It's one of those five. Smell. Yeah. Why does smell basically bypass the thalamus and goes directly ingrained into like memory, the limbic system, as well as like amygdala, like fear sensing? Why is it so important for smell of all those different five senses to go directly to different cortical regions and limbic regions? What can you detect with smell? It's also really like tightly linked with taste as well. Poison, right? You can detect poisons, right? Poisonous things in nature generally taste very bitter, right? And they're going to have smells associated with them as well, right? Smell and taste is very tightly linked. You can also smell spoilage, right? You can smell things that are going to be important for survival. Right? And if you look at other animals, we have a pretty solid olfactory bulb, right? There's actually been some studies done. God, I forgot what university it was. I think it was Stanford, where they were like having students search for a buried piece of chocolate under grass. And they had like students, everything was blind. They were blindfolded. They were covered in like all sorts of like masks and stuff. But the only thing they could use was their smell. And they were actually able to find exactly the location of a buried piece of chocolate. Right? Our smell is actually, it's not as acute as a dog's smell. Dogs have some other features to their ability to smell, but we also have a lot of ability to use our smell as well. Right? Smell is going to be a very important feature of our sensory information. And then other animals, if you look at other animals, they'll have even larger olfactory bulbs relative to the rest of the cortex. Right? If you look at a rodent's olfactory bulb, if you look at a dog's olfactory, a cat's olfactory bulb, even sheep, right? They're going to have pretty big olfactory bulbs in relation to the rest of the brain. So smell is really important for a lot of different organisms, ourselves included. And so it bypasses the thalamus. And we'll talk about that in more detail later. The diencephalon also creates the retina. And then you have the third ventricle, which is associated with this. And then here's your mesencephalon. That just basically turns into the midbrain. Mesencephalon, midbrain. You have the colliculi, superior and inferior colliculi, which we'll talk about later on. That's going to be for both sight and hearing. It alerts you to things that you should be paying attention to. And then also the substantia nigra, which is part of the midbrain. Substantia nigra is what creates dopamine, right? And that's going to be part of the whole motor pathway involving the basal ganglia, for example. And then when you see the rhombencephalon, you have the metencephalon, which creates a portion of your brainstem as well. So this is all brainstem right here, right? Mesencephalon is midbrain, brainstem. Metencephalon is also brainstem, but that's going to be cerebellum and pons. Pons part of the brainstem. Right? The cerebellum is different. The cerebellum is going to be also involved in fine motor control. Right? We'll talk about the cerebellum later on this semester. And then the myelencephalon. Myelencephalon, the way I like to think about this is it's really close to the spinal cord. It's the very first, it's the very last section of the brainstem before you get to the spinal cord. And the spinal cord is surrounded by myelin, right? White matter's on the outside. And so the myelencephalon is right before you get to the spinal cord. And that's going to be your medulla. And the medulla, we'll talk about this again later on, but the medulla is really important for tons of your vital function, right? Heart rate, respiratory rate, right? Vomit reflex, gag reflex, cough reflex. A lot of your reflexes are going to be determined by the medulla. And then you have the spinal cord. So definitely know your embryological derivatives. Super important. And if I remember correctly, this is a video. So this is a cool animation where it's showing all those different structures coming together like like Legos almost, right? Just like getting put together from inside out. Really, really cool animation. Any questions on any of that stuff? No? Cool. So let's get into the cerebral cortex. Yeah.
I have a question. What week is that fully developed? Like the brain, or like what, like trimester?
25 years old is actually when your brain reaches full maturity. Yeah, reaches full maturity at 25. But before that, that's a good question. I don't know off the top of my head. We're going to get into it, but I can't remember. Yeah, I don't want to give you a false number, but we'll talk about this later. I'll look into that and I'll get an answer for you. But fully developed brain. Yeah, I don't want to throw out any figures. I don't know off the top of my head. Good question. Look it up. Look it up and tell me. But yeah, the brain actually reaches full maturity, especially for guys. I think women's a little bit earlier, but guys, we tend to mature a little bit later. So 25 years old for guys. I think it's a little bit younger for ladies. What'd you find? I'd imagine it's
Breaking down everything.
I'd imagine it's somewhere around like week 20, perhaps.
Yeah.
Because a child is viable at week 24 outside of the womb.
Final structures are like going like
Week 21?
week 21.
Cool.
Yeah, sensory development it's like week 17.
Yeah. That makes sense. Cool. All right, so let's get into the cerebral cortex. So these are all the different regions of the cerebral cortex, some of which are going to be relevant to our class, some of which are not going to be relevant. Actually, these are all just different gyri and sulci. The ones that are going to be really important are going to be the precentral gyrus, postcentral gyrus. Right? Precentral gyrus is going to be motor. Postcentral gyrus is going to be sensory. And why is it called as such? It's because these are either in the front or in the back of the central sulcus. The central sulcus is going to be the dividing line that separates the frontal lobe from the parietal lobe. So the frontal lobe does a lot of different things. Right? It's going to be involved in like higher executive function, decision making, planning, all that stuff. But it's also going to be associated with motor function as well. Right? So the precentral gyrus is going to be the main primary motor cortex. Right? In front of that is going to be the motor association areas. That's kind of like where you're starting to develop a goal to move. Right? You're kind of like thinking it out, planning it. And then that information gets sent down to the basal ganglia. The basal ganglia does its thing. And then the basal ganglia basically gives the green light to the precentral gyrus to actually initiate movement. So we'll talk about that whole process later on. It's really remarkable. It happens instantaneously. But there's a lot of working pieces that are associated with that. So super cool. Then you have the parietal lobe, which is going to be the main area that's associated with sensory input. And so you have the somatosensory cortex and also association areas that are a little bit behind that. But then the postcentral gyrus is the primary somatosensory cortex. So we'll talk about that in more detail a little bit later. Let's move on here. And so here's a nice image because it shows all the color. It colors out the regions. So you use a frontal lobe. Right? Frontal lobe is also going to involve a region that's going to be responsible for the production of speech, right? Broca's area. And then you have parietal lobe, which is again going to be associated with sensory afferent information. You're also going to have a portion of speech comprehension in the parietal. It touches the parietal and the temporal lobe. So that's going to be Wernicke's area. And Wernicke's area is responsible for speech interpretation. Right? So interpreting speech and also producing speech that's coherent. So we'll talk about different types of aphasias later on, both Broca's and Wernicke's aphasia. Then you have occipital lobe, and that's going to be the eyes in the back of the head. Right? The occipital lobe is what's responsible for vision. And we're going to talk about vision later on and different vision impairments later on this semester. And then you have the temporal lobe. The temporal lobe sits kind of like next to the ears. So that's one of the big things that's involved in is auditory interpretation, right? Interpreting auditory information. But also there's going to be some memory associated with the temporal lobe. There's also going to be facial recognition associated with the temporal lobe. So the temporal lobe does other things besides auditory information.
And the frontal lobe? Sorry, I didn't hear you.
Frontal lobe does higher executive function. So decisions, planning, Also, memory, too, is going to be associated with the frontal lobe as well. When we get into memory later, you're going to find that memory is actually pretty complex. It involves a lot of different areas, the hippocampus being one part of the limbic system, but it's also going to involve parts of the temporal and frontal lobe as well. But the frontal lobe does memory, decision-making, also planning, also as part of your personality. And then if you move a little bit further back, right, move caudal, you're going to get more motor type function, right? So the more posterior portion of the frontal lobe is going to be motor for the most part. Parietal is going to be sensory interpretation. So touch, pain, temperature, all that stuff is going to be parietal lobe, but also the production of coherent speech interpretation. Wernicke's area touches in the parietal and the temporal lobe. So you see that it's right here at the margin of both of those different brain regions. And then here's the corpus callosum, right, that connects both left and right hemispheres of the brain. So here's another image. There's going to be a lot of images from your textbook that I left in here just for you to, kind of get a better understanding of the structures. Some of the things that I put in the slides, I'm not going to go over in a lot of detail. If it's OYO, again, it's going to be on your own. You can just read up on that if you want. There's a lot of studies that we are going to kind of skim over, but we're not going to go into it too deep. All right. If it's OYO, it's for your own information. So here's some more images. You got regions of the brainstem, midbrain, pons, medulla. You got the colliculi, which is going to be associated with the midbrain. So we'll talk about the superior and inferior colliculi later. You got thalamus, you got hypothalamus, and you got the pituitary gland that sits below. And then here's a nice chart that basically shows kind of what all these regions actually do, right? So you got prefrontal association areas. That's where you're starting to plan movement. You got that Broca's area, which is speech formation, speech production. All right. Then you got the premotor cortex, controlling movement. And you got the primary motor cortex, which is what actually does the movement. Then you got the central sulcus, primary somatosensory cortex, where you get all the interpretation of stimuli, afferent stimuli. A sensory association area, which is going to be kind of also aiding in the ability to interpret that information. And then you have occipital lobe and all the regions that are responsible for vision process, and then temporal lobe. They even bring up here the limbic system, which is kind of great, the limbic association area. The limbic system, we'll talk about this in more detail later on, but one of the coolest parts of the brain. It's going to be associated with fight and flight. It's going to be associated with fear detection, memory. Right? It's a really, really cool part of the brain. So that's a really nice image. All right, so again, frontal lobe, motor, personality, problem solving, planning. Parietal lobe, sensory information, right? Even helps you understand left versus right. Occipital lobe, vision and color. Temporal lobe, hearing and smell as well, and memory and emotional behavior, etc. So here's the corpus callosum. Again, that's what, like you've mentioned, right? It connects both left and right hemispheres. Right? The corpus callosum is going to be really important for that. The brain is lateralized. So if you have a stroke in the right cerebral cortex, it's going to be contralateral in terms of its symptoms. Right? So you're going to have contralateral paralysis and whatnot. So we're going to talk about some different signs and symptoms of stroke and other types of upper versus lower motor neuron lesions later on. And then you also have different types of fibers that are going to be associated with the cerebral cortex. So in the white tracts within the cerebellum, or the cerebrum rather, you're going to have association fibers. Right? Those are going to be on either one or the other side. Right? Then you're going to have commissure fibers that connect. Right? So corpus callosum, for example. And then you're going to have projection fibers that go from the brain all the way down the spinal cord. And so those are your tracts. Right? And different tracts do different things. Right? You got the cortical spinal tract, which is motor. You have spinal thalamic tract, which goes from the spine all the way up to the thalamus. So that's going to be sensory. And so we'll talk about those different tracts later on in more detail. And the corpus callosum, it comes from Latin for tough body. Tough body. Right? And allows for lateralization. Now, again, these split brain procedures were really interesting. They used to be done with greater, more frequently back in the late 20th century. Right? And these procedures are super fascinating. Right? Both sides of your brains have different personalities. There was I was listening to an interview with a patient who had a split brain procedure. And by the way, these patients would recover pretty well. Right? The corpus callosum, if you split the corpus callosum, you can usually still function pretty well afterwards. But very interesting in terms of consciousness, right? Consciousness, like each side of the brain has a different type of consciousness, and they have different personalities. So this lady would wake up in the morning, she would start getting dressed, she would like take a blouse off of the coat hanger, she would start putting the blouse on, and the other hand would start taking that blouse off because it didn't want to wear it and would like start putting it back. So both sides of the brain can be sometimes at odds with each other. And these split brain procedures resulted in some very interesting areas of research when it comes to like being able to see things, detect things in the environment. For example, they would do these experiments where they would have a patient see something only in one visual field, right? So only one side of the brain would be able to see it, and then they would ask the patient, and they would like somehow they would wipe out one side of the brain temporarily, so they wouldn't be able to actually see what they were. So the left side of the brain wouldn't be able to actually see what the patient was looking at, but they would be able to write it down with the right hand, because the part of the brain that was able to actually see the object was wiped out, and then the other side of the brain was actually able to interpret that information by writing it down. But they wouldn't be able to say what it was. They could like write it down, or they could pick it out from like a series of images or something. So a lot of really interesting studies. This is a book that I'm reading right now by he's a physician, Dr. Ian McGillichrist. It's called The Master and His Emissary, and it talks about like the left and right hemisphere and what each of the hemispheres do. There's so many really interesting studies that go into lateralization of the brain. It's really fascinating. And most of us are going to be left brain dominant, right? Left brain dominant. Speech areas are usually going to be like in 90 to 95% of people, it's going to be on the left side of the brain, Wernicke's and Broca's area. But some people are going to be right brain dominant. It's not as common, but right brain dominance usually they're going to be left-handed. Right? Not all left-handed individuals will be right brain dominant, but some are. So you'll find Broca's and Wernicke's area on the right side of the brain instead. And both hemispheres do different things, right? Some, like the right hemisphere is more into like big picture exploration of the environment. Left brain is more associated with like grasping onto like things and ideas. Right? Most people who are right-handed, like when you grasp something, you grasp it usually with your right hand. Right? That means you're left brain dominant. Whereas the right brain is going to be more like exploratory. So super fascinating. So these different procedures that were done back in those days, corpus callosotomy, where they would cut through. This was done for refractory epilepsy. Refractory meaning that it did not, it wouldn't respond to treatment. Right? You could take Depakote, lamotrigine, carbamazepine, and none of these drugs would work for these patients. And if you had grand mal seizures are extremely debilitating. Right? Grand mal seizures start in one area, right? You have a focus, and then that electrical activity goes all the way to the other side of the brain. And now you have the entire brain seizing. Right? And so these split brain procedures were done as a treatment for patients with grand mal seizures. Extremely fascinating stuff. Let's watch a little video on this. Oops.
Now the left hand is coming from the right hemisphere.
For some people, an entire half of their brain can't really communicate with the rest. These are people who have undergone split brain surgery, and it's as if they have two minds in a single brain.
Now the question becomes, what happens when you allow both hands together to try to solve the problem? And what we find out is that they fight over each other. One hand knows how to do it, and one hand does not, and so they more or less squabble.
The human brain contains two sides, the left hemisphere and the right hemisphere, right? And they are connected by a big bundle of fibers. It's called the corpus callosum. All the communication from one side of the brain to the other has to pass through this fiber bundle.
For some people with epilepsy, a seizure in one hemisphere can quickly spread to the other by way of the corpus callosum. But if that bridge is surgically severed, a seizure can no longer cross to the other side of the brain. In addition to treating epilepsy, these surgeries have also led to some astounding research into how the two hemispheres function.
With your left hand, make me the A-OK sign.
To learn more about these fascinating studies, I met two pioneers in the field, Michael Miller and Michael Gazzaniga. Michael Miller asked me to step into his lab to do a few simple tests, just like the ones he's conducted with patients after a split brain surgery.
So Heather, what you're going to see are two shapes. They're going to come up on the screen. Now draw the shape on the left side of the screen with your left hand, and the shape on the right side of the screen with your right hand. And I want you to draw them as quickly as you can at the same time. Okay?
Piece of cake, right?
Beautiful. Okay, not sure what you're drawing over here, but.
Maybe I tried to get the hot The left side of the brain controls most of the right side of the body, and the right side of the brain controls most of the left side of the body.
They start out trying to do different things and then they just sort of like sync up together.
Yeah. It's perfectly normal. So, I mean, what's happening is that the motor commands in one hemisphere, you're interfering with the motor commands in the other hemisphere.
It was basically impossible for me to force my hands to draw two different things at the same time. But for someone whose two hemispheres are disconnected, there's no interference. It's almost as if there's one mind controlling the left hand and a completely different mind controlling the right hand. And it isn't just movement that's split across the hemispheres. Only half of your visual field goes to each side of the brain.
When you're looking straight ahead, everything to the left side of that space goes only to the right hemisphere. And the opposite is true for the right side of the space.
The left part of the brain is where your language and speech centers are. That enables you to talk, enables you to understand language, and all the rest. The right side of your brain is very important in the evaluation of emotions, evaluation of visual space. I'm going to give you a test.
If you look around my nose and I hold up my hands, you tell me how many fingers you see, all right?
How many fingers do you see? You see two, right? Why did you see two? This one went to your left hemisphere. This one went to your right hemisphere, way over the other side of your brain. How does your left hemisphere know about it? That pathway, the corpus callosum. It transfers that information. Now I'm going to split your brain. And I do the same test. How many fingers do I see?
You see anything else?
No.
You see one. You see this one because that goes straight to your left talking hemisphere. This one is still going to your right hemisphere, which has now been disconnected from your left. So your left brain can't talk about this. So you now say you only see one finger, even though your right brain is seeing this finger. It just can't talk about it because the highway that communicates that information has been cut.
Show me with your right hand what you see. Okay. Down, relax. Show me with your left hand what you see. Good.
That's the most remarkable thing to witness. You know, there's this whole other entity in the head that's controlling the body and can understand and remember and feel and think all on its own, completely separate from the other side.
Super cool. By the way, last semester I was trying to integrate as many clips from this documentary. It came out, I believe, last year. Your Brain, Who's in Control. So I'm going to try to pepper those in this semester to the lecture slides because it's absolutely fascinating. They do a really good job at exploring a lot of these different topics. Really cool stuff. So split brain procedures, extremely, extremely fascinating. Another thing that's interesting that they mentioned over there, the right brain is going to be associated with emotion. And I'm a guitar player. I play music like piano and all this stuff. And I was thinking, like, most guitar players, right? It's like so they're left hands. And is guitar kind of like an emotional instrument? Yeah, it's
I
a very.
play when I'm like.
When you're bummed out, yeah. No, seriously, like that. I play the best music. I write the best music when I'm like in the dumps, and yeah, it's a very emotional thing.
I don't know, when I go camping with all my friends and like.
Yeah, it's also uplifting too.
It's uplifting.
Yeah, it's uplifting. And so think about a lot of string instruments: violin, right? Cello, right? Left hand that does most of the work. So really, really amazing stuff. Yeah.
So after this procedure, if there's still seizure activity happening on one side of the
It's
brain,
isolated to the one side.
so would the other side, so if the left side has seizure activity, would the right side start convulsing?
If it was on the left side of the brain?
Yeah.
Yeah, exactly.
Okay,
Yep,
just
absolutely. It
wanted
wouldn't.
to know.
Yeah, so it'd be more akin to a complex partial seizure.
Okay,
Right.
so would
Right.
you still try to treat the
Yeah,
seizure?
of course,
Okay.
absolutely. Yeah, I mean, I imagine that they were still taking their anti-epileptic meds after the procedure just to reduce the activity. Right, that's the whole purpose of a lot of those drugs. They're there to reduce the brain activity. Yeah, so anti-epileptic meds tend to make individuals a little bit drowsy, a little bit sluggish, right? Because that's the goal, is to reduce electrical firing from the neurons. But yeah, that's a really great question. It would only be isolated to one side of the brain. And then one side of the body, the opposite side. All right, frontal lobe, right? That's going to be, again, involved in personality, emotions, judgment, memory, sexual behaviors, right? This is going to be the high executive function of your brain, right? Your higher executive functioning. And frontal lobe, again, is going to involve motor areas. So you got primary motor cortex right here, right? That's going to be the precentral gyrus, motor association area, and then the prefrontal cortex. The prefrontal cortex is really what contributes to your personality. Prefrontal cortex is going to be what really makes who you are as an individual. And the thing about the brain, which is really fascinating, is that you got subcortical areas like the limbic system, which is kind of like the lizard brain, if you will, right? When you hear people say, "Oh, the lizard brain," meaning like it's just an animal just doing its instincts, right? We have the same type of thing in us as well, right? The frontal lobe is really what helps to control those more primal instincts. If you have frontal lobe damage, you tend to become very impulsive, inappropriate, violent sometimes. Right? If you look at a lot of our prisoner systems, if you look at a lot of psychopathy, for example, I'm going to play a video later on about a guy who studies psychopathy. His name is Dr. Fallon. I forget his first name. Dr. Fallon. Jimmy Fallon. Yeah, it is. It's Dr. Jim Fallon. Yeah, not to be confused by the actor, but Dr. Jim Fallon, and he's a researcher, I think, out of Stanford, one of those schools, somewhere in California. But he studies psychopathy, and a lot of the prisoners who are psychopathic will have reduced activity of the frontal lobe. And so, if you have reduced activity of the frontal lobe, what takes over? It's going to be your more primal instincts, right? Sex offenders, violent criminals, right? They're basically acting on their instinctual urges. Right? If you didn't have a frontal lobe, you'd be just like a dog. And what does a female and a male dog do? And it doesn't matter if you're watching or if they're in public, right? Female and male dogs will just go at it, right in front of you. It's like, what's going on over here? Calm down, dude. Right? That's what people do if you get frontal lobe damage, right? You'd be acting on your urges, right? So a lot of sex offenders, and then also what happens if a dog sees food in front of them? Right? It's just going to gobble it up without even thinking about it sometimes, right? And so that's kind of what the lizard brain does. That's what like your more primal, like the limbic system, the thalamus, hypothalamus, and all that stuff is going to be involved in those like primal urges. And so thank God for the frontal lobe. Otherwise, we would be absolute animals. And this is one of the most famous cases of frontal lobe damage, right? Phineas Gage, one of my heroes. I really like this guy a lot. He's awesome. So, you guys know about Phineas Gage? So the story about Phineas Gage is fascinating. The dude was a railroad foreman. He was like an upstanding Christian. He was married. He was living a really upstanding life. He was a railroad foreman, so he's basically like managing teams of railroad workers back in those days. So he's a really well put together dude. Then one day on the work site, the dynamite didn't go off. And so he went out there to inspect why the dynamite didn't go off. And he carried this tamponing rod with him and poked around a little bit. And then the dynamite blew off. And the rod went careening right through his skull. So it entered in through the maxilla. So it took out the maxilla. It wiped out his left eye. And it went careening out at the top of the frontal bone, right? And so it basically wiped out a whole portion of his frontal lobe. And afterwards, they sutured his eye shut, right? Because he had no more eye anymore. So they just sutured it shut. And the doctor, here's another thing before we get there. He gets up right away. So the heat from the explosion, it heat up the tamponing rod so hot that it basically cauterized everything. So he wasn't really bleeding from the injury. He got up, walked over to his buddies, and as soon as he started talking, they started noticing CSF flowing out of the wound. And they're like, you need to go see a doctor. And so he did. He went to go see a doctor, and he saw this guy, Dr. Harlow, and this is one of my favorite medical notes on a patient. Dr. Harlow writes, "He is fitful, irreverent, indulging at times in the grossest profanity, which was not previously his custom, manifesting but little deference for his fellows, impatient of restraint or advice when it conflicts with the desires, at times pertinaciously obstinate, yet capricious and vacillating, devising many plans of future operations which are no sooner arranged than they are abandoned in turn for others appearing more feasible." So that's one hell of a medical note. Great description. So notice, he's irreverent. He's indulging in profanity. This dude used to be like an upstanding Christian guy, attending church, really, excellent member of the community. And then he became basically like a brute. He kind of became an asshole. And so he's just going around cursing and swearing and also very impulsive, right? He comes up with an idea. He's got these flight of ideas, but he doesn't pursue any of them because he gets distracted easily. So pretty wild story. So really amazing guy. Now, here's the thing that's interesting about his story. And unfortunately, when I was in med school, this really pissed me off because I actually really like this guy a lot. He's one of my favorite guys in neuroscience. I read up a lot about this guy. And it turns out that about 2 years later or so, he went back to baseline, or at least close to baseline. He actually improved substantially. This behavior of his was pretty much temporary. It was in the aftermath of the incident, and then eventually he kind of got better. So what's the term that we use for the brain kind of rewiring and fixing things that might occur through injuries, for instance?
Metaplasia?
No, not metaplasia.
Oh. Other classes.
Metaplasia, not metaplasia. That's where one cell type turns into another cell type, like Barrett's esophagus, for example. Yeah, neuroplasticity. If a person gets a stroke, what does the person do? If they're young enough, they can go to rehab. They can go physical therapy and hopefully regain some of what they lost from the stroke. Same thing with this. The brain will rewire. It will create new synaptic connections so that it can help to try to achieve a baseline, right? Try to go back to what it used to be able to do. Not always perfect, right? Some lesions are too intense, too dramatic, right? And the brain can't necessarily fix those. But this is a case where he did eventually come back to baseline. Yeah.
I don't know if you read up on this. This is probably a detailed question, but do you think a different part of his brain became the prefrontal cortex at the expense?
The other side.
Okay.
I don't know if at the expense of it, but
did he lose a certain
yeah,
whatever that part?
It's permanently lost. Yeah, that area was permanently lost, but the other part of the brain, I think, was able to compensate. Right, so there's compensatory mechanisms that come into play. So with strokes, neuronal damage, sometimes if you have a stroke, you'll get rewiring of motor neurons. So they can recruit different muscle groups to try to make up for what was lost.
So
And
like
it takes time.
The old part of the brain that like the prefrontal cortex kind of took over.
Yeah.
Was that just the other half of the prefrontal cortex?
Yeah, basically.
So did it just become more efficient, or is it like a hierarchy?
That's a really good question. I would imagine efficiency. I would imagine a lot of things. Efficiency, also just like new neuronal synaptic connections. Yeah, just rewiring. So it's possible. It does happen. And it's a really cool thing here. His skull is actually in the Harvard Medical School Museum. And they did a 3D rendering of the skull. And you can download the file online and do a 3D print. You guys know my colleague, Dr. Jackson? Yeah, Dr. David Jackson has Phineas Gage's skull in his office. And he's got this like cool little like LED light rod that goes through it so it lights up. Dr. Jackson is really into like 3D prints and lighting things up. So this is where we're going to start next time we meet. So this is Jim Fallon. We'll watch this video on Jim Fallon because he is such a fascinating individual for many reasons. So we'll talk about him next time. You guys have any questions? Today we're going to continue where we left off last time. And last time we were talking about Phineas Gage. Right? Remarkable story. Amazing that he survived. And then not only survived this massive injury to his frontal lobe, but he also, again, kind of went back to his baseline over time. It took a while, but neuroplasticity, right? Your brain is capable of forming new connections. And this happens throughout your lifespan. Right? And we'll talk about learning and memory and all that stuff later, and how neuroplasticity is one of those things that can help to buttress yourself against neurodegenerative diseases like Alzheimer's. Right? So frontal lobe damage is also going to be associated with psychopathy. Now, the frontal lobe is really what governs the more primal regions of your brain. So the subcortical regions, including limbic system, are going to be what are there for your more innate type instincts. So drives like sex drives, feeding, thirst, all the basic stuff, even like fighting, fight and flight. A lot of that's going to be governed by the subcortical regions within the diencephalon, limbic system, right? Thalamus, hypothalamus, and all that. If the frontal lobe is damaged for whatever reason, then you are not able to actually control and regulate those regions. And this was one of the main focuses of Jim Fallon. So Dr. Jim Fallon is a professor, UC Irvine. I can't remember what school he teaches at, but yeah, UC Irvine. Yeah, so he was doing a lot of studies on the brains of psychopaths in the prison system. And so what they were doing was PET scans to see the activity of the brain. And you'll find that a lot of psychopaths have reduced frontal lobe activity. And that's just something that they're kind of born with. We'll also learn about later on people with ADHD also have reduced frontal lobe activity. And that's why if you take a drug like a psychostimulant, like Adderall, which is just amphetamine salts, Vyvanse, drugs of that nature, those drugs are stimulants. They help to stimulate the frontal lobe better. And so it helps to alleviate the effects of ADHD. So we'll learn about that later on. But if you have reduced frontal lobe activity, you will have a tendency for violence. However, in his studies, he found out that he also has the brain of a psychopath, which is pretty amazing. They did a brain scan on his whole family. He thought the graduate students on his team were actually playing a trick on him, and they like slid in like one of the psychopath brains into the brain scans. And he was like, "What is this? This is like the brain of a psychopath. This is crazy." And then he's like, "Find out who this is." And then they're like, "It's actually you." And then in this video that I'm going to play, he doesn't talk about it in this video. He talks about it in a different video, where his wife, she's like, yeah. She's like, "I kind of had a feeling that you have psychopathic instincts," because he lacks empathy tremendously. He doesn't talk about it in this video, but he would talk about how he would go to a funeral and he wouldn't feel any emotions, but he would pretend to feel emotions. He would feign sadness because he felt like it was expected of him, right? In a social type of setting, he's expected to look sad, where in reality, he doesn't actually feel any emotions whatsoever. And so that's pretty wild stuff. Yeah.
Would taking Adderall help?
That's a really good question. That's a really good question, and I don't know. Maybe look that up. That's kind of fascinating. Maybe there's a lot of impulsivity in ADHD, right? Individuals with ADHD tend to be very impulsive, and they get highly distractible, right? That's why when you do take those types of psychostimulants, it can help to reduce distractibility and increase focus. So who knows? Maybe I'm not sure. Yeah.
Have you heard of people taking like ashwagandha recently?
Ashwagandha, yeah.
Make yourself less emotional.
Less emotional. I never heard of that. No. Yeah, ashwagandha is it's a mushroom, isn't it?
Yeah.
Or is it
like a herb?
An herb?
Yeah.
It's an herb.
Yeah.
I heard something too.
Interesting.
Yeah, like people are taking it in like gummy form in order to like feel less emotion. It makes you more like stable.
Is it like it can have antidepressant type properties?
Yeah, apparently.
I'm gonna have to look into that because I love herbal medicine as a whole, but I don't really know much about ashwagandha. So let me put it on my list of things to look up.
I heard it's not like a side effect. Because I know people take it for have them stay calm with anxiety and stuff. Eventually, like they stay that like they feel the need now.
That is super cool. I'll have to look it up. I'll have to look that up. So let's watch a little video on exploring the minds of psychopaths. So this is a talk that Dr. Jim Fallon gave. Yeah.
Actually makes it worse.
Oh man, really? That's funny. All right, hold on a second. Let me download uBlock Origin so I can not have to see any YouTube ads. I hate that stuff. Okay. So Adderall and those types of drugs make psychopathy worse.
Yeah, it says like you increase your dopamine, you can feel more aggressive.
Oh wow. Okay, that makes sense. Oh, hold on a second. I'm like, why is there no volume to this? There we go. Sorry about that. Hold on a second. This is not the video I wanted to play. That's a longer version. I think this is the one. Oh, they changed these. They changed these links. It's kind of interesting. So this is the longer version of the video. I'm not going to play the entire thing. This is actually the video that I usually play because it's shorter. I'll play this video. You guys can watch the link for the other one on your own time. I highly recommend it because it is very interesting, but it is kind of long. I don't want to play the whole thing in this class, but I will play this entire one because this is a very good video.
Neuroscientist, professor at the University of California, and over the past 35 years, I study behavior, but on the basis of everything from genes through neurotransmitters, dopamine, things like that, all the way through circuit analysis. So that's what I normally do. But then, for some reason, I got into something else just recently, and it all grew out of one of my colleagues asked me to analyze a bunch of brains of psychopathic killers. And so this would be the typical talk I would give, and the question is, how do you end up with a psychopathic killer? What I mean by psychopathic killer are these people, these types of people. And so some of the brains that I've studied are people you know about. When I get the brains, I don't know what I'm looking at. It was a blind experiment. They give me normal people and everything. So I looked at about 70 of these and came up and saw a number of pieces of data. So we look at these sorts of things theoretically on the basis of genetics and brain damage and the interaction with the environment and exactly how that machine works. So we're interested in exactly where in the brain, what's the most important part of the brain. So we've been looking at this, the interaction of genes, what's called epigenetic effects, brain damage, and environment, and how these are timed. And how you end up with a psychopath and a killer depends on exactly when the damage occurs. It's really a very precisely timed thing. You get different kinds of psychopaths. So we're going along with this, and here's just to give you the pattern. And the pattern is that those people, every one of them they looked at, who was a murderer and was a serial killer, had damage to the orbital cortex, which is right above the eyes, the orbits, and also the anterior part of the temporal lobe. So there's this pattern that every one of them had, but they all were a little different too. They had other sorts of brain damage. The key thing is that the major violence genes is called the MAOA gene. And there's a variant of this gene that is in the normal population. Some of you have this. And it's sex-linked. It's on the X chromosome. And so in this way, you can only get it from your mother. And in fact, this is probably why mostly men, boys, are psychopathic killers, are very aggressive. Because, the daughter can get one X from the father, one X from the mother is kind of diluted out. But for a son, you can only get the X chromosome from his mother. So this is how it's passed from mother to son. And it has to do with too much serotonin during development. It's kind of interesting because serotonin is supposed to make you calm and relaxed. But if you have this gene in utero, your brain is bathed in this, so your whole brain becomes insensitive to serotonin, so it doesn't work, later on. And I had given this one talk in Israel just this past year, and it does have some consequences. And theoretically, what this means is that in order to express this gene in a violent way, very early on, before puberty, you have to be involved in something that's really traumatic. Not a little stress, not being spanked or something, but really seeing violence or being involved in it in 3D. Right? This is how the mirror neuron system works. And so, if you have that gene and you see a lot of violence in a certain situation, this is the recipe for disaster, absolute disaster. And what I think might happen in these areas of the world where we have constant violence, you end up having generations of kids that are seeing all this violence. And if I was a young girl somewhere in a violent area, 14-year-old, I want, I'd find a mate, I'd find some tough guy, right, to protect me. Well, what the problem is, this tends to concentrate these genes. And now the boys and the girls get them. So I think after several generations, and there's the idea, we really have a tinderbox. So that was the idea. But then my mother said to me, I hear you've been going around talking about psychopathic killers. And you're talking as if you come from a normal family. I said, what the hell are you talking about? She then told me about her own family tree. Now, she blamed this on my father's side, of course. This was one of these cases, because she has no violence in her background. But my father did. Well, she said there's good news and bad news. One of your cousins is at Cornell, founding Cornell University. But the bad news is that your cousin is also Lizzie Borden. Now, I said, okay, so what? We have Lizzie. She goes, no, it gets worse. Read this book. And here's this Killed Strangely. It's a historical book. And the first murder of a mother by a son was my great-great-great-great-grandfather. Okay, so that's the first case of matricide. And the book is very interesting. It's about, witch trials and how people thought back then. But it doesn't stop there. There were 7 more men on my father's side, starting then, Cornell's, that were all murderers. Okay? Now, this, gives one a little pause. Because my father himself and my 3 uncles in World War II were all conscientious objectors, so were pussycats. But every once in a while, Lizzie Borden, like 3 times a century, and we're kind of due. And so the moral of the story is, people in glass houses shouldn't throw stones, but more likely is this. Okay? And we had to take action. Now our kids found out about it, and they all seem to be okay, but our grandkids are going to be kind of concerned here. So what we've done is I started doing PET scans of everybody in the family. And we started PET scans, EEGs, and genetic analysis to see where the bad news is. Now the only person, it turns out, one son and one daughter, siblings, didn't get along, and their patterns are exactly the same. They have the same brain and the same EEG, and now they're as close as can be. But there's going to be bad news somewhere, and we don't know where it's going to pop up. So that's right there.
So if you watch that other video that I linked into the slides, he's going to go into more detail about all the stuff that I was mentioning, that, all of the, him feigning sadness and all that stuff. He's a really, really fascinating guy. He does lots of really good work. So another thing that he talks about too is the biopsychosocial model of disease, right? And so just because he has the brain of a psychopath doesn't necessarily mean that he's going to act it out, right? We all have things that are like, biological issues, but they don't ultimately determine our fate, right? Just because we have a biological propensity, think about it as like risk factors, right? If your parents have risk factors for cardiovascular disease, like say, for example, your dad had a heart attack at 50, if you keep up with your health, you're aware of your risk factor, and you have a good diet, lifestyle, exercise, all that, then you're able to maybe protect yourself from those risk factors. Same thing with like neurological conditions, right? If you have risk factors for certain neurological conditions, doesn't necessarily mean that it's going to manifest phenotypically. You might have the genotype, maybe, right? But maybe phenotypically it doesn't express. So you guys ever heard of the biopsychosocial model of illness? It was posited originally by a family doctor. I forget the guy's name, but it was posited back, I think, in the late 20th century. And it really, really kind of overlaps with a lot of psychiatric and neurological conditions. So when we say biopsychosocial, we're talking biological determinants, psychological determinants, and your social determinants, right? So if the biology, like Jim, right, he has the biological predisposing factors for psychopathy, right? He has it. It's part of his genetic makeup, right? Obviously, psychopathy runs in his family. However, psychosocial, his psychological predispositions are good, right? He's psychologically sound. He's psychologically stable, right? He's well integrated in society. And socially, he has a wife, he has a family, he has a good job at a really good, reputable university. So those other factors help to protect him against those biological determinants. Whereas if he, as a child, was beaten by his parents, if he had experienced adverse childhood experiences, right, seeing traumatic experiences, being a victim of traumatic experiences, right, then he probably would have manifested those tendencies as an adult, right? So biopsychosocial model of disease is a really important thing to keep in mind. And you guys are going to be looking at this later on when we do our second assignment in the semester, when we do the AI-assisted mind mapping assignment, because we're going to be looking at the biopsychosocial determinants of different types of illnesses. Okay. Any questions about any of that stuff? So we'll be revisiting that later on. So the prefrontal cortex, right? This is going to be, again, your high executive function. It's going to be involved in abstract reasoning, working memory, decision-making, planning, right? Executing those plans in a stable way, right? You can also abstract, right? So you can perform abstract intellectual activities. It's also really good for memory. So there's a lot of regions in the brain that are going to be responsible for memory. The frontal lobe is going to be one of them. It's going to be good for short-term memory, right? And a lot of your long-term memory is going to be stored in part in the hippocampus, right? So the hippocampus, portions of the temporal lobe, and the prefrontal cortex are all going to be associated with memory. And later on, we're going to learn about anterograde versus retrograde memory and the things that can affect memory, especially when it comes to memory loss. And here's the little fun piece of medical history, right? Lobotomies, right? Which later on evolved into leucotomies. Leucotomy meaning leuco means white. And so over time, the lobotomy sort of became a leucotomy. And they were wiping out basically the white myelinated tracts of the frontal lobe. And leucotomies were something that were pioneered by this guy, Antonio Egas Moniz, in 1936. And this was originally used to treat psychosis, schizophrenia, those types of conditions. But over time, it got out of control. Right? First of all, that is out of control to begin with. Like using this as a treatment for psychopathy is not a good idea. But then beyond that, they started to use it for all sorts of other things. For depression, bipolar, PTSD, right? Brain damaged patients, uncooperative patients. Totally insane. It wasn't uncommon for a husband to be like, yeah, my wife's acting out of control. Doc, please take care of her. And I don't know if I mentioned this the other day, but that's what happened with John F. Kennedy's sister. JFK's sister was lobotomized. Totally insane. This happened regularly. It was very common. And oftentimes the procedure wouldn't really work well. Surprise, surprise, right? Some patients, if they had psychosis, they would not be psychotic anymore, but they would kind of just be like vegetated, sedated, right? It's a terrible, horrible procedure. And dude won a Nobel Prize in 1949 for physiology or medicine. Totally nuts. So we look back at these types of things with horror, right? It's awful stuff. But it's kind of cool. You can actually still buy those kits, the leucotomy kits. Look it up online. I really want to get one. I want to get one so bad so I can just like bring it into class and be like, hey, this is my lobotomy kit. Who wants to get lobotomized? Anybody who cheats on the exam will be lobotomized. Speaking of penetrating injuries through the brain, this is another famous case. This guy in 1978, he was a particle physicist in Russia, and he had a proton beam penetrate through his skull. And so it kind of like destroyed parts of his brain. So it went through the occipital lobe, temporal lobe of the brain. It like damaged his face, like part of his face became paralyzed. He like swelled, part of his face swelled beyond recognition. Totally wild. He lost part of hearing in his ear. He developed tinnitus. But then over time, he was able to recover from the injuries for the most part. However, he developed seizures as a consequence. So permanently damaged his brain in terms of seizures. Right? So that's a pretty wild story. Really incredible case. Now, when it comes to motor function, this basal ganglia is going to be one of the major regions that helps to control motor function in terms of initiating movement and inhibiting movement. And we're going to get really deep into the weeds with this later on. But the basal ganglia helps to initiate movement. So when you're planning on executing a movement, that's going to be the basal ganglia that gives the green light, thumbs up, says, yes, go ahead and make that movement. Or it also inhibits unwanted movements. Right? If the basal ganglia isn't working properly and you can't inhibit those movements, that's when you develop Huntington's disease. Right? Huntington's disease is a hyperkinetic type of disorder where the patient uncontrollably moves. They can't stop moving. It's awful. And we're going to get into that in more detail later on this semester. The opposite of Huntington's is going to be Parkinson's disease. And Parkinson's disease is where you have the inability to initiate movement. So in other words, the part of the basal ganglia that inhibits movement is what takes over. And then you can't initiate movement. And we'll talk about the direct and indirect pathways with the dopaminergic pathway later on. Right, so that's going to be the nigrostriatal pathway. We'll discuss that much later when we get more deep into the basal ganglia. But it's those types of movement disorders are really tragic. Huntington's disease, I wouldn't wish on my worst enemy. It's like one of the worst conditions out there. Right? The patient cannot move, cannot control their movements. And I'll show you some videos of individuals with Huntington's disease. And it's really sad. Then you have the cerebellum, and the cerebellum is also going to be involved in controlling movement. And so if somebody has cerebellum damage, they're going to have really rough movements. So touch my finger, and then touch your nose. Now touch my finger. Now touch your nose. Touch my finger. Touch your nose. Good. So her cerebellum works. So if she didn't have a functioning cerebellum, she'd be like doing this, like kind of squiggling in the air, right, until reaching my finger. Right? And that's how you test in the clinical setting if a patient has cerebellum damage. Another thing that you can also do with cerebellum damage patients as a test is a thing called a pronator drift. And pronator drift, I don't know if I have a video of it in here. I don't, not for this at least. The pronator drift is where you have the patient, usually you want them either sitting down, or if they're standing up, you want to stand up behind them just in case they lose balance. But sitting down would probably be a better way to do it. But what you do is you have the patient close their eyes, and then you have them have their hands supine, so pointing towards the ceiling, and you sit there and wait for a minute and see what happens. And if they do have damage to different motor tracts, including the cerebellum, they might start doing this. Their hand, as it's straight forward, begins to pronate and drift off to the side laterally. So that's called pronator drift. Another thing you can do too is you can kind of like push your hands down and see if it goes back into place, right? Their hands will reflexively go back into place, right? So that's the way that you can test their ability to control movement in a clinical setting. So yeah, cerebellum damage, you can also watch them. They'll have different types of gaits, which will affect their ability to walk, because the cerebellum is responsible for your posture, controlling your movements, etc. It also helps. It's also in part responsible for controlling like the planning of movement as well.